Moving on to the humerus. When we palpate the humerus relative to the acromion process, the humerus should protrude slightly in front of the acromion process, but no more than a third of its thickness. When we look at the elbow, the antecubital creases should face anteriorly and the olecranon should be facing posteriorly, and the proximal and distal ends of the humerus should be in the same vertical plane. It's important to make sure that the scapula is correctly positioned when assessing the glenohumeral joint position, because if the scapula is abnormally positioned and the humerus looks as though it's in a normal position, that may be enough indication for or enough stress for an impingement problem or a shoulder problem. Here we can see somebody who's got an excessively anteriorly positioned humerus. We can see that the humeral head is clearly bulging forward on this side. Sometimes the humeral head may appear to be superior, so it may appear to sit very high relative to the acromion process. And occasionally the humerus itself is held in a physiologically abnormal position. So here we can see this girl's left shoulder, the distal end of the humerus is clearly sitting further away than the upper end of the humerus. So again, the scapular position looks fairly normal, but the angle of the humerus is completely wrong. Excessive medial rotation can be identified by the cubital fossa facing excessively medially. And again, it's important that the clinician identifies whether this excessive medial rotation is as a result of scapular position or humeral position. Similarly, with a laterally rotated humerus, it's important to note whether the scapula is sitting in the correct position. This is far less common than an excessively medially rotated humerus. The humerus may be held in excessive flexion and extension, and again the easiest way to identify this is to look at the humerus from the lateral aspect. If the head of the humerus is sitting forward relative to the inferior aspect of the humerus, or the inferior end of the humerus, then that's an extended position. If the upper end is sitting backward relative to the inferior end, then that's an excessively flexed position. Having looked at the posture of the thoracic spine, the scapula and the humerus itself, we then move on to assessing the movements in the shoulder region. And we start off with shoulder girdle motions, and the shoulder girdle can move upwards and downwards, elevation and depression. It can ab and adduct, and it can rotate. It can upward rotate and or downward rotate. For normal upper limb function, the shoulder girdle and the humerus must be in an ideal starting position. These are our normal ranges of movement. The upper limb should be able to flex approximately 180 degrees, extend about 50 to 60 degrees, abduct to about 100 degrees, but then as we then rotate the limb, we should be able to complete this movement through to elevation, through to 180 degrees of elevation, and then adduct to approximately 45 degrees, and then medial and lateral rotation, we should have about 90 degrees of both of those movements. But there should be an accurate interrelationship between the shoulder joint and shoulder girdle movement, both in terms of quality, quantity and rhythm. When looking for scapular motions, we need to be able to see if the scapula can effectively rotate upwards and rotate downwards. Upward rotation is a very important movement where the inferior angle moves away from the midline relative to the rest of the scapula. This presents the glenoid fossa in a more superior direction to allow full elevation of the upper limb. Medial rotation or downward rotation is the opposite movement, and this occurs during the lowering of the upper limb. In elevation, the scapula glides superiorly relative to the thoracic spine, for example, shrugging the shoulders. And depression is where the scapula glides down. The movements of abduction and adduction are where the scapula moves around the thoracic wall. Adduction is where the scapula retracts and the medial border moves towards the vertebral column. Abduction is where the medial border moves away from the vertebral column. In addition to that, the scapula can tilt anteriorly, and this is where the inferior angle moves posteriorly, moves away from the thorax itself, and the acromion process and coracoid process move downwards and forwards over the thoracic cage. Winging, as mentioned earlier, is where the vertebral border moves away from the rib cage itself, and this is often associated with weakness or an inability to effectively contract the serratus anterior muscle. As mentioned earlier, it's important to ensure that the starting alignment of these structures of the scapula, the humerus and the thoracic are ideal, as abnormal starting alignment may lead to abnormal scapular motion and abnormal glenohumeral joint motion. You may come across the term scapulohumeral rhythm, and this refers to the timing and the quantity of movement of the scapula relative to the humerus during normal motion. Under normal activity, for every 1 degree that the scapula moves, the humerus should move 2 degrees. So, for example, if we go through the movement of abduction through to full elevation, where we end up at 180 degrees from our starting position, 60 degrees of that should occur at scapulothoracic motion, and only about 120 degrees occurs at the glenohumeral joint. If there's inadequate scapulothoracic motion, the glenohumeral joint may compensate, and it may lead to signs of instability and or impingement. Rhythm is also about timing, and Inman and Saunders in 1944 produced a wonderful paper to describe the timing of the scapula relative to the humerus. A number of more recent studies, although we've got some fairly old ones listed here, have also reported variability in timing of that motion. So it's not a hard and fast rule, but these are guidelines. The clinician assessing the patient should look at both sides, compare left to right, and look for symmetry in particular. Scapular motion often ends as we move through flexion at approximately 140 degrees. The remaining movement, the remaining 40 degrees, typically occurs at the glenohumeral joint. Palpating the inferior angle of the scapula, if the clinician palpates the inferior angle of the scapula, allows accurate observation of scapular movement, and say comparing unilateral and bilateral motion is important. Here we can see asymmetry of scapular motion. So if we look at this scapula, we can see there's an excessive rotation of the scapula here. There's a lot of rotation compared to this side. So it's this asymmetry that we look for. If you palpate the scapula itself, if we palpate the inferior angle here, relative to the root of the spine of the scapula, when the individual is at full elevation, we should observe approximately 60 degrees of rotation. And this diagram we've got a prime example of somebody who's got completely inadequate serratus anterior, so when they lift their arm, the load of the arm in itself is sufficient to cause a lifting of the scapula. So there's no stability of the scapula itself. The scapula instead wings, which then leads to altered joint kinematics at the glenohumeral joint, and this can increase the risk of impingement in this region. The end of the range of motion, the scapula should be seen to depress slightly, to posteriorly tilt slightly, and adduct a little bit. This is to move the coracoacromial arch out of the way to allow full motion of the glenohumeral joint. And stiffness of the thoracic spine and inability for the thoracic spine to fully extend, and or tightness of pectoralis minor can lead to a disruption in this movement.